Hello, welcome to Wellbeing. I'm Guy Murphy. When health professionals connect patients with community activities and support services to improve well-being, addressing social needs alongside medical care in daily life, that's called social prescribing. Today we'll learn more about it. My guest today is Dragana Vidovic from the University of Essex. Thank you for coming on the show today, Dragana.
Oh, thank you very much for inviting me. It's a pleasure to be with you.
So we'll be focusing on Dragana's study, Can Social Prescribing Foster Individual and Community Wellbeing? A systematic review of the evidence. And this was published in 2021, is that correct?
That's right. That feels like a while ago.
Fantastic. So could you please give us a quick introduction and, tell us what got you into working in research in this field?
What brought me into, and I'm very glad you're asking a reflective question like this one, made me think about, what I've been doing before and after I got into social prescribing. And what brought me into the research was my long-standing interest and work in civic and community engagement. And so over the years, I've been working and leading a number of volunteer and community sector projects. And they all kind of focused on working with people in local communities to better understand and improve the conditions in which they live. And so a lot of work that I've done was around empowering communities through knowledge exchange, skills development, and figuring out how social support can help people manage their health better, find better opportunities for themselves. And so it kind of extended from there. And so this was some of my early interests. And based on this, I got a scholarship in early 2000s to study psychology at a college of St. Benedict in Minnesota, U.S. And it just kind of continued from then. So I moved, after completing my psychology degree, I moved into political studies and political science area, and I still continue to think about social and community engagement. And so I then studied in-depth social movements as part of my degree, but I kept thinking, how do I link it all back to psychology? So once I got the opportunity to link better psychology and political science, I took that on, and that was through this project called Connected Communities. So this is the first time where I really go deeply to understand what social prescribing is. And this was in 2019, which is a very significant year for social prescribing here in the UK. So I worked on this project called Connected Communities for several years. And the goal of the project was to offer a 12-week personalized care to socially isolated people in the UK, 3 regions in the UK and 1 region in France. And University of Essex was in charge of evaluation. And I worked closely with Professor Gina Reinhardt, who is one of the co-authors of the paper you mentioned. And she led the project and the evaluation. So it was quite interesting. That's how I got into the area of social prescribing. But the interest in community life and community engagement has really been something I've been interested throughout my whole life. And I still continue to work with Professor Reinhardt on another project that is very much centered around community well-being, place-based interventions. And so we are working again on the similar coastline, starting from Norfolk down to Kent. So it's the east-south side of England. And we are working to address issues of a variety of issues that coastal communities are facing. We are talking to people to, first of all, understand what these issues are. And in general, we are looking to address and advance resilience in coastal communities. And the project is called ARISE, and it's short for Advancing Resilience and Innovation for a Sustainable Environment.
Fantastic.
So, still continue at the University of Essex and continue to be in this field.
Awesome. Well, it's a very interesting line of research and something that I think is quite important and probably even more so important since the pandemic.
Absolutely. It's amazing to see people coming back into spaces that they've occupied before and trying to find their footing again. on who remained in the area which they live, who feels more comfortable to be coming out in their shell again and get to know their community and work with others. And so, it's absolutely fascinating to see how people as well start to think about how to incorporate what they've learned throughout COVID, using digital solutions to connect with each other, how they can use these tools to their benefit.
Absolutely. Alrighty, well, I've got some questions for you about the study and about your research. So, it seems that social prescribing isn't a new concept. From memory, I think it has been around since the 70s, correct me if I'm wrong on that, but it seems like it's a little bit overlooked potentially. Would you agree with that comment?
Yes, you're absolutely right. It's not a new model, especially in the UK, which, from what I know historically, like you say, has been present since 1970s. But what is relatively new is this formal recognition that, especially here, that within the National Health Services, there's this effort to embed it into healthcare, where we have dedicated social prescribing professionals. They're called various names like link workers, connectors, prescribers. So they are delivering this project under the guidance of, first in 2019. So just as I started the Connected Communities project work with Professor Reinhardt, and we planned a couple of years of how the project would look like, there's this mandate, NHS long-term plan that got published in January 2019 that provided a significant funding support and any other legislative support to have much more social prescribers in the field and working through NHS. So this effort to standardize it and recognize it formally as an important model in public health has really brought it to the forefront in the UK and then globally, internationally, really from there and spread. And so even though it's not new model and it's now part of the National Health Service infrastructure in the UK and it's very much present internationally as well, it can still be overlooked in practice. And I don't know about other countries, but I think here one of the reasons for that would be because the GPs, the general health practitioners, family doctors, I don't know, how do you refer to them in Australia? I should have checked. They are really under huge pressure, and they have been for a while, because there is such a high demand on healthcare service across the board. So there is very limited time that the GPs have with each patient, and not every GP practice has access to link workers, as the National Health Service kind of rolls this role out. And so if GPs don't have access to link workers, they might not always know what community groups or activities are available locally, and these things might change over time, and what groups exist. And so it really is a challenge to deliver it if the structure is not there. And so that is potentially why it's being overlooked. And also, I guess, because the health systems are set to primarily respond to medical needs using medications and tests rather than, social relational support, I think the training for GP doctors is not there yet. And so if they don't have that extra support, then it would be a challenge for them as well.
Yeah, absolutely. Interesting. And moving on, in this line of research, it appears that there are potentially some gaps, such as, a lack of randomized controlled trials and other means of causal inference. Why are these so rare in social prescribing research? Is it an ethical issue or something else?
So you're absolutely right. There are some big gaps in the research, especially when it comes to randomized controlled trials. And there are a couple of reasons I can think why that would be. First, people would like to use medical model to evaluate social prescribing, but social prescribing is a different kind of intervention. It's not like giving somebody a pill and then measuring what happens.
Yeah.
You can much more control what happens there, because you know what medications person has, what conditions they have, and the only thing you're changing is the medication that they're taking to test to see if it works. Social prescribing is a social initiative, and really it unfolds in much more dynamic and relational ways. So to capture all that, it's quite challenging. But I guess because it was developed as part of NHS, the National Health Service model, then it kind of had that thinking attached to it that, yes, this is intervention and we will assess it and we'll see if something changes. And so we have, social prescribing will depend, the success and the way it's implemented will depend so much on the networks of people and organizations that exist at that time that are working in the community. It will, there are so many interactions that happen between individuals who are receiving it, communities in which they live, places that they're referred to, and then the way that service takes them back in to see how things have progressed. So it's really not a kind of fixed dose like a medication. It's very flexible, it's context sensitive, and it has so many things that person could ask to, anything people would like to be involved in art and potentially physical exercise and also volunteer at the same time. And so a person could be interested in so many of these things, or maybe just one. And so there's quite a lot to why randomized control trials wouldn't be easy possible. But like you say, they're also... go ahead.
I suppose I was just asking, it'd be kind of hard to design and configure in such a way that would show a really clear causal relationship.
Absolutely. There's just so much variability. But then there are also real ethical challenges, like you say. How do you justify randomly assigning people to receive social support or not receive support to, have a trial and control group? So for people who are struggling with loneliness, isolation, or any other social health needs, it really would be impossible and unethical to
randomly assign them to a social group. No, that makes complete sense. You're listening to Wellbeing. My guest today is Dragana Vidovic from the University of Essex, who is a researcher in community and wellbeing. So do you think that these gaps in the literature and these difficulties that people face in drawing these causal inferences and that sort of thing, did these impact policy making in the area, and is that why this has been sort of a thing that has been very slowly implemented since its inception in the 70s?
I think it could be one of the reasons. The other reason why it took time from 70s to 2019 is a real attention to social needs and recognizing them as very much relevant. So what precedes social prescribing, this kind of movement and the power that it really came to in 2019, is a number of things that happen and quite a lot of research in psychology dating from 2000s on, especially in social neuroscience, where researchers are showing these very significant impacts of loneliness on a variety of physical and mental health conditions. And loneliness becomes this topic where there's research coming out that it's linked to early deaths, cardiovascular health, depression, anxiety, all of these things. And then there are some key events that happen in the UK in particular, where there was an assassination of Joe Cox MP from the north part of the country, and she was quite beloved. And so the catalyst she was murdered, unfortunately, by a person who was then later described in newspapers as a lonely individual. And so there's this kind of catalyst of things that happened, that there was a need for a model that would recognize that there is a social need to be considered, not just what's happening with people physically. And that I guess it would be interesting to know who at what point figured it out to think about that a number of GP appointments, as they are now estimating, is due to loneliness and isolation. How that was observed the first time, that would be really interesting to know. But I think there's a lot that happens in research, but as well as in the community, where people are seeking to find a model that would incorporate social health into understanding of the overall health. And that ended up being social prescribing, because there are several good examples of projects of that kind of work in the UK. And there was just a lot of willingness from every side. It really is a most interesting cross-sectoral collaboration between governments, voluntary community sector, and interest from public and health and social care as well. But less so social care. I think they're, for whatever reason, not as prominent as healthcare, who are funding parts of this. But yeah, there's a bit of a scare on how bad loneliness is for health. And then the COVID happens, and then all of this stuff, it's very kind of, I think it's brought it to the forefront. And that's why it almost needed a couple of decades to cook itself to come to the surface.
Okay, fair enough. So have there been any major developments or clear conclusions that have been drawn on the topic of social prescription since your study in 2021?
Oh, yeah, there have been some really important major developments since 2021. And, picture is still evolving, but there's quite a lot of improvements in conceptual clarity and the way in which social prescribing is being assessed. So one very important work was by colleagues in Canada who have developed and worked to develop the internationally accepted definition of social prescribing.
Okay.
And so they've brought together researchers, I guess representatives, people who work in the field of social prescribing. The study was done in 2023, so they brought experts from 26 countries to look through this method called Delphi method to reach a consensus on what social prescribing is. It's absolutely essential and a fantastic example of work. It was a study by Kate Lemieux, Kate Mulligan, and a couple of others. So I can't remember other researchers. They are based at Queen's University and University of Toronto in Canada. And so what they had like one short and one long definition of social prescribing. And it's very impressive to see that level of consensus being reached across international space, where they defined it as social prescribing being this model where trusted individuals, either in clinical or community setting, can identify that there is a person that needs or has non-medical needs, and social prescribing similar types of models could help individuals, connect them to non-clinical support, connect them better to community and to others in the community. And so the goal is to work with the person and provide and co-develop a personalized care. What matters to this individual and what resources exist in the community to help somebody improve their health. So conceptually, that was the most significant achievement. And anyone
Fantastic.
Working in the field really is benefiting from this work.
Absolutely.
It was really something. The other really, really important effort, and this has happened more recently, again, there's so many organizations that work in the field of social prescribing, so if you leave one of them, it just feels so unfair because there's just so many groups, and I know more about the UK because that's the field that I'm most familiar with. But, for instance, there is a now National Centre for Social Prescribing Data and Analysis here in the UK, which was established by the University College London research group and a National Academy for Social Prescribing that is a organization that doesn't just link social prescribers here in the UK, but it's globally recognized as a place that supports anyone who works in social prescribing. They run international social prescribing collaborative, of which many Australian organizations are part of as well. And so this National Center for Social Prescribing Data Analysis is going to be amazing. They hope to create a long-term national strategy for collecting and analyzing data on social prescribing that would then help inform policy and practice. And it's an amazing effort to see of what they're hoping to achieve, and they're already starting to produce. And so now we have, as I say, much stronger definitions. There's better understanding of data collection and protocols, but also limitations. People are, more willing to talk about limitations of their particular study or the field in general, so that there is quite a lot of willingness to understand it better.
Fantastic.
And the third thing, and the third thing that I really, really don't want to forget to mention is a really significant progress was making link workers, social prescribers, connectors a profession, so providing a standardization for that. Which, when we started Connected Communities in 2019, Professor Reinhardt and we were designing, a job description role for social prescribers. We didn't have an exact copy from somewhere where we could say, our role would consist of this. And so we were creating our own role. I remember writing up a report, and we were thinking of how it would look like, because Connected Communities was hiring social prescribers in UK and France. And so we had the complexity of two different languages as well, which was fun. But there are now formal training standards, career pathways, and the role is recognized within the National Health Service. So it really is going to be a huge help with providing more consistency in how the service is delivered, the quality of it, and it will improve evidence base. So these three things are just a fantastic achievement. From 2019 until now, it's 6 or so years. It's fantastic.
Absolutely. No, those sound like huge developments. It's great to hear as well, that there are sort of better definitions for these terms, because, in your research you did recommend standardized definitions and metrics in future research. That's great to hear.
Yeah, and it's also very impressive to see how people are quickly now picking up on these developments and incorporating these advancements in their research. So, and I think part of it is really because a lot of organizations that have worked either in the field of loneliness or social connection before have really found a good way to join this effort to develop social prescribing further. So, like, for instance, Campaign to End Loneliness or Mental Health Foundation, or a number of organizations here. It really feels unfair to mention just some. But, like centers like Bromley by Bow Centre, Paris Health Hub in the UK. So many organizations who are in the field are working very closely to think tanks and groups that are looking to bring people together to collaborate, to discuss what is loneliness and how do we measure it and how do we build consensus around methods and approaches. And I know, like, this was another thing that I just remembered when we were starting Connected Communities. We were thinking we would need to do the whole study on, figuring out there are a number of measurements and ways to assess loneliness. And so we thought we would have to really figure out how to create or choose the best one that would fit us. And so UK government, for instance, has at that time produced this did assessment of a variety of measures and assessed them on validity and provided this whole work and provided a standard of what would be the best way to assess loneliness. And so there are these 4 questions that everyone now uses. And so, again, not just from the research organizations, but also there's efforts from government here in the UK to facilitate a lot of this effort, which is fantastic.
That's great. So these dedicated social prescribing workers, are they GPs or are they link workers or are they both? What's their sort of classification?
So that's interesting and a good point to clarify. So they are not GPs, they are not general practitioners. What they are, it's like if you could imagine somebody sitting in the field of health and social care, but knows a lot about community. So they are their own profession now, and they know something about health system to understand what people's needs could be from that side to be informed. They know something about social care in case the person is coming from being referred from that side, or any other service in the UK. So they know a little bit about each of the services where people could come from. People also could refer themselves into a social prescribing initiative here in the UK. So you could just see a pamphlet somewhere, and you can think, you know what, this could help me. I think I need to be part of Men's Shed Group, which is this group that gets together and does a lot of carpentry work or handiwork, and it's a very interesting place. And so you could ask them if you could be part of it, and they would find a social prescriber that could help you, or you just come and attend the classes. So social prescriber is somebody who knows a little bit about how the local services and systems work, but knows a lot about community, so that they could understand, once the person presents with a particular need and describes what matters to them, what's going on in their life, what's affecting their health and well-being, and what are their interests and strengths and what they would like to improve, understand about themselves. And people can present themselves with a number of issues, anything from loneliness to, feeling anxious, to have long-term health conditions. And this is the most complex one, where people can have a number of conditions, anything ranging from, having a recent stroke to having a number of comorbid physical and mental health conditions. People having financial issues, being carers and feeling overwhelmed, losing somebody who matters to them. So all of these kind of health needs that are linked to social aspects of health, people can present all of these. And so social prescribers would know how to work with people to explore what is going on in their life and what matters to them. How would they like and could envision their life to be better? And given the amount of information they know about resources that exist in the community, they can then match the need with a resource that is there to help people feel better and start to improve their life. And so they just, have more time, much more time than GPs. I think GP appointment here is like 10 minutes. And if you don't manage to speak fast or explain yourself well, So, they work with people to produce or co-produce a personalized plan of what the person would do over a particular number of weeks, where they work with social prescriber. And so there's a lot of counseling, and I guess just being there present, listening to people is a big skill. That would be something that social prescribers would be very, very skilled.
Okay, interesting. If you were designing a large-scale social prescribing trial right now, what would your ideal study look like?
It's a great question, and I thought of this so often as we were implementing connected communities, and as we are now working on a rise and being, out there with people and getting to know what issues are in a particular community and how people are, addressing these. And so it would really need to be rigorous, academically rigorous, but also a realistic approach. And so I feel like recognizing the context-specific nature of social prescribing, and, as I said, people would present or could present themselves with a number of health issues that range in the severity and the comorbidity and all of this. And so there would really need to be a good, realistic thinking of the context and the place in which, thinking and understanding of it, what is happening with a particular person or particular community, and to really communicate well of what is possible and what is achievable with a project that you have through the prism of rigorous study, because as part of the work that we do is to produce academic outputs that need to be then defensible and presentable and useful to policymakers, to others who are designing intervention and so on. So I think the first thing I would do is work with community to really understand where goals and type of outputs that academics need to produce are, and what can then benefit the community. But I thought a little bit about this, and in terms of designing a study, because there is so much talk about randomized control trials and so on. One way to find causal inferences and be more certain about some of these conclusions we make would be, for instance, using the cluster randomized trials. So instead of thinking about how to randomly assign individual people to intervention, or control, you could actually randomize the whole cluster. So you could have like a GP practice being a cluster, or community organization or whatever that people are being referred to for social prescribing. And so you could have some GP practices receive social prescribing and others don't. Others just continue as they are. So that's exactly what's happening now in the field as more social prescribing support. There's a new plan here in the UK, 2025 health plan, Fit for Future England or something like that, where social prescribing is really center of personalized care, and it's a model that will be here to stay, and that for the next 10 years will be financially and in other ways supported. So we have already GP practices where social prescribing is very much part of it, and we have those that are not. And so it would be a simple thing to compare the outcomes, either in terms of, health, individual health or community connections or things like that. And it's, a very good way to get to some of these causal critiques and issues that social prescribing faces. And that would be one of the things I would try. And then study that I would love to do is to better understand the whole network of organizations that it takes to deliver social prescribing. So I would use some type of social network analysis. I haven't yet figured this out, but it would be amazing to really understand better how people connect to each other and community resources through social prescribing, and what are the best ways to map and measure these relationships and networks that emerge as people are participating in social prescribing, both online and in person, and really, really show how it works, what types of connections, what types of activities or networks are driving these changes, if there are changes that are observed in well-being, participation, healthcare usage, whatever the outcome
Absolutely.
of interest is. So, yeah.
Fantastic. Well, that's exciting. I really like the idea of, using the cluster design with the GPs and so on. I think that's a great way of bringing that sort of randomized control to a study.
Yeah. There's so much work in this field. It's amazing.
Absolutely. Now, you mentioned, online socializing, and I just wanted to finish up with a question about that. So, over the past 2 decades, the popularity of online communities has grown and grown, particularly in recent years with the advent of COVID-19. Do you believe this could also be an effective method of bringing people together and reducing health system usage, or do you think in-person interaction is irreplaceable and, incomparable in terms of its health benefits and so on?
Yes, I would say these two types, in-person versus digital interaction, probably shape relationships in their own unique and likely different ways. And they both probably contribute, could be useful in bringing people together. So, I don't know, there's so many digital communities where people share their advice on their health, on community life, on how to navigate a particular service. So it's a resource that shouldn't be discarded in any way, because there's just so much. This is a space where people are exchanging tips, ideas, learning from others. And through this, it's very important to then capture or use that part of online groups to help people interact better. I recall, as we were working again with the Connected Community study, there was this neighborly lab group, research group we brought to do a presentation for us. And they've shown in their research that, for instance, WhatsApp groups, they're more than just digital chat spaces. They were actually, they showed that these are critical tools that would bring people together and provide space for them to connect and ask for support. And they are not just for, keeping people online in this faraway space. They could actually then encourage the real world interaction. People would inform each other about particular meetings that are happening. There are clubs in a community. And so they are sending people from these online spaces. They're acting like gateway to bring people out to meet in a real world. And so, all of this could be helpful for social prescribing and any other projects of similar nature. So I think, using both in-person and online interactions, some kind of blended approach is really definitely something to do, especially, for instance, in like rural areas where we are now working with the Arise project. There are people who are far away from services or community spaces. They might have mobility issues. They might not lack transport access. They're far away from main centers. And so these online spaces would really be helpful for people to connect, and maybe the only way to actually stay in touch with others, like what happened during COVID. So, both very useful.
Interesting. Well, thank you for sharing your thoughts on that. But thank you very much for joining me on the show today, Dragana.
Oh, thank you very much for the invitation, and I really enjoyed talking about and thinking about social prescribing. And it is a field here to stay, and it gains really a high recognition here in the UK. I mean, even King Charles is publicly supported it. So, what other program has support of the king? So
yeah, that's huge.
Yeah.
Very interesting.
Well, thank you very much, guys.
Not a problem. My guest today was Dragana Vidovic. Thank you again for joining us on the show, and thank you for listening. I'm Guy Murphy, and all of us at Wellbeing wish you well.